Hello, good afternoon. Welcome to another series of webinars from the HeartBrothers Foundation. Today we have the privilege of having Dr. Camille Kotton, infectious disease extraordinaire, with us. Dr. Kotton, uh, she's the clinical director of transplant and immunocompromised host infectious disease. She's at Mass General. She spends the majority of her time seeing patients and outpatients before and after solid organ transplant and bone marrow transplant. She also has a great interest in travel medicine, vaccination, and travel medicine for the transplant patients. With that very short bio, I'm going to turn it over to Dr. Kotton. But before I do that, I just want to take a moment to thank our sponsors, Transmedics Corporation, Cytokinetics, and SC Pharma, and uh, the last item, even though with Dr. Cotton is a phenomenal infectious disease physician and all, please do not change your regimen or your treatment plan without consulting with your transplant center or with your own physician. With that, Dr. Cotton, please.
Great. Well, thanks very much. It's really a pleasure to be with you all today. Um, I'm honored to join you again. It's been a little while. So I will talk about updates on respiratory infections, vaccines, and also travel medicine for heart failure and for organ transplant recipients. So where are we now? This is actually overall pretty good news, I think. So there's the state of Massachusetts does this reporting, and of emergency room visits during the last week, 12.3% were for acute respiratory disease. And, the influenza severity level is moderate. I'll talk a little more about that. I think we're on the way down, but we're still seeing flu. And fortunately, the emergency room COVID-19 visit level is minimal. And then COVID-19 hospital admissions level is low, and it's really low. It's just a handful of patients. And I'm very happy to say that we have not seen a transplant patient admitted for quite a while now. So that is wonderful news. Overall, in the state of Massachusetts, just over 21% have had the updated COVID-19 vaccine since last September. So that's very disappointing because it is recommended for 100%. And then just over 41% are vaccinated against influenza, and influenza vaccination is actually recommended for everyone. So again, those numbers are lower than they should be. We are missing an opportunity to protect ourselves. So COVID-19, so in general, levels are down. We are no longer reporting national numbers the way we were, but we are looking at wastewater. And I'm sure many of you are very familiar with this information, where for many different infections, we can actually look at sewage. I never thought sewage would be so exciting. But we can look at things like monkeypox and polio and whatnot, and including COVID-19. So this has been a big part of our database. When we look at the national map, you can see that some places in gray have insufficient data, but most places are either minimal in white, or the lighter the green, the less wastewater viral activity there is. So, you have a couple states down south, a couple states up in the north. New Hampshire and Vermont are a little closer to moderate than we would like. But overall, I mean, this map has really, fortunately, faded over time. So we are seeing a lot less COVID-19, and this is, just wonderful news. Another way to look at it would be to divide up the country by either national data in black, or the South is that purple line there that, we're still seeing higher levels in the South in wastewater, but overall the numbers are really trending down. You can see this peak that occurred around the end of December. And, I think many people got sick around that time. And then here we are, where the numbers are just trending down and down and down. It does seem that we've seen a peak around the end of the year, beginning of the year, for a couple of years in a row now. So we are wondering if that's the future. But the good news is numbers are really trending down. We hope it'll stay that way. Vaccines have really been a game changer. Here's specific numbers for the state of Massachusetts. This is the South Shore, which looks a lot like the North Shore, but you can see the numbers again are trending really down over time. So this is all good news. And then also the state of Massachusetts still does keep keeps the number of cases. It's just not done on such a national level, but you can see the number of cases have really fallen over the course of since the beginning of the year. And then similarly, deaths have also really fallen, and it's really overall a small, still unfortunate, but small number of deaths per week. And we do know that a good number of those people could have been better vaccinated and were not, so missed opportunities. But overall, I think this is pretty happy news. And with multiple vaccines, we're really in a much, much better place. So where are we with vaccines? So I sit on the CDC Advisory Committee for Immunization Practice, so we make national vaccine policy. And in September, we recommended that everyone 6 months of age and older get an updated COVID-19 vaccine. So that's the 2023-2024 formula. And then in late February, we said that anyone who is 65 years of age or over should get another dose of vaccine at least 4 months after the last dose. So for people over the age of 65, kind of 2 doses per year, sort of like every 6 months is a good goal. And I would say the same thing for moderate or severely immunocompromised people. So heart transplant recipients are moderately, sometimes severely, but usually moderately immunocompromised. And I'm recommending that everybody get a vaccine every 6 months. And I think that, if you've had disease infection recently, you could wait a couple of months, but I do think COVID-19 vaccines every 6 months is sort of the way to go. Some people express frustration that they need to keep getting vaccines, but the fact I wore my seatbelt yesterday in the car doesn't really help me today. There are things that we just need to do to maintain ongoing protection. So there is a new monoclonal antibody that was just approved within the past month that's called Pemgarda or Pemivibart. So it is a new monoclonal antibody to prevent COVID-19 in moderate to severely immunocompromised people. This should not take the place of vaccination. Like vaccination, we think is still much better. For most people, it is better to have an updated dose of vaccine than to try to get this. The wholesale price of Pemgarda, the base price is over $5,600. We don't know about insurance coverage yet. And it takes a 1-hour infusion plus 2 hours of monitoring because there is a risk of anaphylactic reaction, so severe allergic reaction. And so far, I know at Mass General, we have not set up a program. I don't believe that anywhere else in town has set up a program. And it's really not clear that we need to be giving this. I think the days of Evusheld were really different. Also, Evusheld was free and supplied by the government. And I will tell you on the back end, the rollout of Evusheld was hard. I personally was doing injections in clinic myself. And I don't know that this will be a large scale rollout. There are some people who are on drugs like rituximab or who've undergone bone marrow or stem cell transplant. But in general, I don't think that this is something that most heart transplant patients would need as long as they're up to date on their vaccines. Although, as was said, you should talk to your provider about that. What about influenza? So we are still seeing, here, we're still seeing more flu than we would like kind of late in the year. And you can see that we are in Massachusetts, we are still kind of the higher end of moderate disease activity. Same in New York. We have some low in New Hampshire, low in Rhode Island, but we have more influenza than we'd like, and we are still seeing cases of influenza come in. So these are the things that, COVID-19, we have treatment for. If you've got COVID-19, we encourage all people with either heart failure or heart transplant to get treatment, and same for influenza. We have oseltamivir, which the trade name is Tamiflu. It's also recommended that people get the annual influenza vaccine, so a flu shot every fall. And I do want to be clear, so for the past few years, we've used a quadrivalent vaccine. So quad means four, so it covers four different influenza strains. And then luckily, we have noticed that one of those influenza strains is no longer circulating. So we kind of put it out of commission. So starting this coming year, we with the WHO and the CDC and much of the world will be using trivalent vaccines. So only 3 strains would be covered. So some people might be suspicious, like, oh, are they cheaping out on me? I like my quadrivalent. There's a lot of uproar, at least in my community. You know, I want the 4, I don't want the 3, but we don't need to cover 4 now. And so anyway, so you may notice that you're getting a trivalent. And then for people 65 years of age and over, it is recommended that they get either higher dose or what's called adjuvanted influenza vaccines. You can talk to your provider about that, but there are special vaccines for people 65 years of age and over. And unfortunately for transplant patients, we are working on this at the CDC level, but so far we can't give anything but the usual for people under the age of 65, as it's not covered by insurance unless you have a way of getting it in a clinic or somewhere else where they're routinely giving these either higher dose or adjuvanted vaccines, which in theory I would recommend, but because they're not covered by insurance, it becomes kind of impossible to, or not very possible for many people to get. Okay, and the last one I'm going to talk about is respiratory syncytial virus, or RSV. So honestly, probably none of you had really heard about RSV, and then all of a sudden you start seeing these ads on TV, and lo and behold, yes, so we've learned about RSV, which is one of the top most common respiratory viruses that we see, and it does cause significant illness. You can see in this map that similar to influenza and similar to COVID, sort of every fall, we start seeing a peak in sort of October, November, December for RSV. So there's a lot of RSV around. There are no effective antiviral treatments. So unlike influenza and COVID-19, there's no treatment for it, which is sad but true. But there is a vaccine now. And so this past year, there was a recommendation that everyone 60 years of age and over talk with their physician, and if recommended, that they get this RSV vaccine. And I do actually recommend it for all patients with heart failure who are 60 or over, and all patients who've undergone heart transplant. Here's a list of the diseases that are for people who would be at special need for RSV vaccine. And you can see I highlighted moderate or severe immunocompromise, but I will say I spent much of the day yesterday talking about heart failure, and that those patients with heart failure are at higher risk for severe RSV disease. So a good reason to get vaccines. At this point, unfortunately, if you're under the age of 60, it's not approved or not recommended for you at this time, which is true, but sort of not much we can do about it. The vaccines are close to $400 each, so it's hard to get the vaccine. Yeah, hard to get the vaccine if it's not covered by insurance. RSV vaccines are generally available at commercial pharmacies. And are free if you have Medicare Part D, which is 50 million Americans. And so far, private insurance has a year or longer to figure out coverage. So if you wanted it this past year and you're on private insurance, it may be available to you this coming year. And I would still, for all of these and more, there's parainfluenza, there are other viruses out there, human metapneumovirus and whatnot. We've learned so much during the pandemic. I think it's great to just embrace how much we learned. Masking works, hand hygiene works. You know, whenever if I ride on a plane, I wear a mask. I mean, if I'm in a crowded place, slip on a mask. I don't feel like getting sick. We've learned a lot. We can empower ourselves. And we still do recommend that transplant patients consider wearing masks, especially in higher risk settings, crowds. I always think when people come to the hospital, there are a lot of sick people in the hospital, so it's a good place to wear a mask. I personally wear a mask in the elevators, in the hallways. I just don't need to be breathing other people's germs. I don't want to get sick. I don't, and I would never want my patients to get sick from me. Um, and, we did a good, this year at Mass General, we sort of looked at all the respiratory virus numbers. And when the numbers really started going up, we had masking for all staff, and the numbers have now gone down. And so we've stopped mandatory masking. Although many of us on the transplant team still wear masks because we figured out it's a good idea. Okay, so that's it on respiratory viruses. I'm happy to take questions about that at the end, but now let's talk about the fun stuff, which is travel after transplant. So, um, travel can, depending on where you're going, there can be a higher risk of infection. We don't worry too much about travel to Europe, Canada, Australia, New Zealand, and sort of a brief stay in a resort in the Caribbean, is generally pretty low risk. If you want to look yourself, the CDC has a great website. You can actually, it's this travel destinations, but what you in a Google search, you could put CDC destinations, Bahamas or, Bermuda, wherever you want to go. And it gives you a lot of up-to-date information. I actually use it if you come to see me in travel clinic. That's often what I'm doing on the other side on the doctor side of it. I'm just reviewing, and are there any outbreaks? Is there anything going on that I need to know about? Is there any unexpected disease activity that we should be discussing in clinic? And the CDC does a great job with this. And then say you're thinking like, should I go to country A, B, or C? You can actually look at this travel destinations. You can look at Costa Rica. You can compare it with, I don't know, Mexico or Canada or wherever. So that's a pretty cool list. And then for some destinations, you might need malaria medicine, specific vaccines, and other travel related issues. And if you do want to be seen, I know that there are people from different institutions, so you should go probably to your own institution. But if anybody wants to come to travel after transplant clinic, you can always call my office, and I'm happy to see people for that. This is one of the more joyous things that I do, in that people have gone through a lot. They've gone through a lot of hospitalization, medical issues. They've felt poorly. And then maybe they want to go visit friends and relatives. Maybe it's a special wedding or a special, family event, and they want to travel. And it brings me great joy when people can travel again. So I'm happy to support them in their journey. And overall, I have, touch wood, I have a very good track record of keeping people healthy and well during travel. I do think that transplant patients are especially good in that they know that if they get sick in a foreign country, it's going to be kind of a mess. So they tend to be a little more careful. Of destinations, it's good if you can skip the areas sort of in this darker yellow or mustard color, in that there's yellow fever in these areas. So if you want to go to Africa, I do recommend, say, Southern Africa, Zimbabwe, South Africa, Botswana, Namibia. There are some areas in, Tanzania that would be reasonably safe. But if you just want to go on safari, if that's your dream, South Africa, Botswana, they have amazing safaris there. And then there's also better healthcare than some of the other locations. And then for South America, we can't give the yellow fever vaccine. And so the trip down the Amazon would not be recommended unless you had a yellow fever vaccine prior to transplant. But because this is a live viral vaccine, we do encourage people to kind of skip going to these areas. In addition, I think travel to the Indian subcontinent, so India, Pakistan, Bangladesh, in general results in higher rates of infection. I do see many people who want to go home and visit friends and relatives, and so we figure out ways to keep them healthy and well. But if you're contemplating travel, there are some areas that are lower risk and higher risk of infection. I do get a lot of questions about cruises. And so cruise travel seems nice in that, you don't have to journey too hard or journey too much or work too hard to be on a cruise. But there are a lot of cruise ship associated illnesses. And as you can see, there have been bad COVID outbreaks, sometimes influenza outbreaks. There have certainly been the norovirus, like where people get horrible vomiting and diarrhea, which can be pretty devastating to a transplant patient. And then seasickness and sunburns, bug bites. And so if you decide to go on a cruise, and personally, I do recommend, I'd rather you go to a resort on land, in that we do see a good amount of illness on ships. And then if you decide you do want to go on a cruise, just think about the plan in case you get sick when you're on the ship, and where you would have like medical evacuation too if you were to be, really, really sick on a ship. So food for thought. There's a really good website by the CDC that has all this information on cruise ship travel, and they actually rate some of the cruise ship lines and whatnot. So you can actually get a lot of information there. I think it's really, really, really helpful. So just in summary, there's never been a better or safer time to prevent vaccine preventable illness. It's really like we know so much about COVID vaccines, incredibly safe overall. We just had a really big report come out from the government where they analyzed millions and millions of COVID-19 vaccine doses, and just lots of safety and protection data. Things have really changed. I am so happy as an infectious disease specialist. It's rare that we see severe COVID-19 anymore. We do recommend staying up to date on your influenza vaccine every fall, and up to date on COVID-19 vaccines again every 6 months. For heart transplant patients. And then for transplant patients who are 60 and over, we do recommend the RSV vaccine. And then think about travel after transplant, and potentially coming to see me if needed. And that's it. I think I'll stop sharing, and happy to take some questions.
So thank you very much, Dr. Kotton. Great, great. I have many questions, but I'm going to take the question from the others. So this is a question from a lady. With increase of measles, even if MMR up to date, would you recommend heart transplant patients get measles titer if travel?
Yes, that's from Jill Powers. Okay, that is such a great question. And we honestly don't know exactly what to do about that. I have to say, measles was really on the increase just before COVID-19 hit, and we were quite worried about it. And then COVID-19 came and everyone huddled. And so we didn't see spread of measles, but now we're seeing a lot more measles. And with vaccine hesitancy in the United States and elsewhere, we're seeing a lot more measles. We've had measles in Philadelphia, Chicago, California, certainly Florida. And so, yeah, you don't even have to travel. You could go to the grocery store. Measles is a challenging topic because the measles vaccine is live, viral, and adult transplant patients should definitely not get that vaccine for now. Hopefully, people all had MMR vaccine, mumps, measles, rubella vaccines as children, or as you were being evaluated for transplant. For over almost 20 years now at Mass General, we've checked everyone, and if their antibody titers are low, then we vaccinate them before transplant. Unfortunately, we still have people out there who are not well protected against measles. And so, unfortunately, we don't have anything we can do about that. If you are exposed to measles, we can give you an infusion of intravenous immunoglobulin. But that would be hard because if you were, traveling in Africa or wherever you are, it might actually be really hard to come by the preventative that needs to be given within 6 days for optimal prevention. So measles is an important issue. If you can show, if you have your vaccine records, so if you can show that you had 2 doses of measles vaccine in the past, the CDC says that that should qualify you as being protected. We don't exactly know how to interpret titers, and in that some people are vaccinated and protected but may have a low titer. So we don't really know what to do. I think the short answer is the best answer is find your pediatric vaccine records and try to get all your vaccine information. And if you've had 2 doses of measles vaccine, which would be true for people born from about the late 70s and onwards, we were very good about getting 2 doses of measles vaccine. But there's a risk group of people born between 1957 and the late 70s who are probably less well protected against measles. And that's why anyone with heart failure who's looking at heart transplant, if you're listening, we would want to make sure that you take this opportunity to get an MMR vaccine, a measles vaccine, prior to undergoing immunosuppression.
Thank
I
you,
loved
Doctor.
it. I love that Jill asked that question because that's actually, I'm doing a lot of research on that front. So yes, talking to the CDC about that one. That's a hot topic. She nailed the hot topic right up front.
Great. Thank you, Jill. Any other questions? So I had an anticipation of this program. I put some questions together. So the first is treatment of COVID-19. The Paxlovid is basically the common #1 medication all non-transplanted patients get for COVID-19. So how does that work with transplant patients? And if not Paxlovid, then what? What is a good treatment?
Yeah, so most transplant patients are on tacrolimus or cyclosporin or sirolimus or everolimus. So it makes drug dosing really challenging because of really potent drug interactions. So usually we go with either intravenous remdesivir, which is kind of our #1 pick for transplant patients, intravenous remdesivir. Although depends where people live. In many locations, it can be hard to find or hard to get the infusions. Nothing's as easy as it was during the height of the pandemic. I never thought I'd say that actually, but it's true. And so if you can't get intravenous remdesivir, then I usually recommend molnupiravir. Molnupiravir, molniravir, molnupiravir. And that is generally well tolerated, very well tolerated. It doesn't have any drug interactions. We think it's less effective, but we do worry a lot about the drug interactions. So it makes Paxlovid not a good choice for transplant patients. Some people stop the tacrolimus during the time people are on Paxlovid, but we are reluctant to do that where we have alternatives. We did have a transplant patient get Paxlovid and showed up at the Brigham. And for those of you that know your tacrolimus levels, and they're usually like 4 or 6 or 8, the tacrolimus level was 90. So
Ooh,
that's bad. Yeah, I know. You don't get extra points for that.
no.
Yeah, it was not good. So that's a good question. I also, for travel medicine, I do recommend molnupiravir. If your physician will give you some molnupiravir for travel, I do recommend that people take it with them. Technically, we're sort of not really supposed to be writing those prescriptions, but I think it's a really good idea to travel with test kits for COVID-19 and then travel with treatment. And so I know myself, I was in Argentina when I fell ill and I don't have health insurance or, I don't have doctors there to take care of me. I know some doctors, and so I was pretty happy to have some treatment ready to start when I was in Argentina. And I think for transplant patients, especially, it would be good to have what we call like pill in hand ready for self-treatment. So I think that that would be a good part of travel medicine.
So if someone is traveling doctor and they came to your clinic, you would, even though they weren't sick, as a prophylactic, you would prescribe medication for them to take on a trip.
To take with them, and then if they develop COVID symptoms, they would test, and if they so they would test, and if they test positive, then they would start treatment. We do that for other things too. Like we often give Cipro as a prescription and then don't take it. But if you get sick and if you get horrible diarrhea, bloody diarrhea, that kind of thing when traveling, you can just start treating yourself. So that's a pretty standard travel medicine thing that just in case. Luckily, most of my patients never take this stuff, but just in case, it wards off the evil eye during travel.
Okay. And for everyone, Jill put some good information in the Q&A about here. Let me. So just an FYI, MedJet Assist, different from travel insurance, as additional coverage will get you to a hospital of your choice. It is fairly inexpensive. And then the next question is from Phil. I don't want to attempt your last name, Phil. I don't want to mess it up, but Gozul. My apologies if I don't pronounce it correctly. What do you know about the new dengue fever vaccine? Is it something that I should get if I go to Bali?
Yeah. Well, Jill, thanks for the tip about MedJet Assist. Whenever you're doing any of these insurance coverages, I would just make sure that it's not like pre-existing conditions aren't covered or anything like that. Um, I am a little suspicious of insurance companies. And so just make sure that, they would actually trigger the coverage and not try to get out of it, those rascals. And then thanks to Phil for the question about dengue fever vaccines. So right now there are no dengue. Okay, Jill says MedJet, no pre-existing condition clause. Does that mean there is no pre-existing condition clause, like that pre-existing conditions are okay? I'm assuming you're meaning yes. Thank you. And then for Phil, so there are no dengue fever vaccines under evaluation now in the United States. There is very little dengue fever in the United States, and I think companies don't necessarily want to take on the FDA, is sort of my understanding. There is Puerto Rico is part of the United States, and there's a good amount of dengue fever there, but for whatever reason, Takeda had a dengue fever vaccine under evaluation in the US, but they withdrew from the FDA. So there are multiple dengue fever vaccines out there. They're about to start a large scale campaign in Brazil that will probably really knock dengue off its feet, which is fabulous. It's a live vaccine and contraindicated in immunocompromised people. And so far, all the dengue fever and chikungunya vaccines being developed are live viral vaccines, so not for transplant patients. I have, because I'm on the National Committee on Vaccines, I have publicly every time expressed my displeasure at that because I say it's close to 7% of the US population is now estimated to be immunocompromised. And I think we need to make sure that immunocompromised have, access to good vaccines, same as non-immunocompromised. I do wave that flag every single time. Actually, when I raise my hand, they usually start laughing because they say, we know what she's going to say now. She's waving the immunocompromised. The transplant flag. I say, yes, I am. I'm here to represent.
Great. So one of my other questions was, with the approach of summer and the increase of mosquitoes, you hear a lot about mosquito-borne diseases. Is that a risk? What is the risk? How do you mitigate it? Is there certain places in the United States that are higher risk than others?
That's a great question. So, yeah, ticks and mosquitoes. So, whenever possible, we do recommend that people avoid tick and mosquito bites. So mosquito bites, you can cover up with clothing. You can try to be away from areas with a lot of mosquitoes. You can, mosquitoes are often biting sort of at dusk. And so you can, if you're in a really buggy area, you can just try to get yourself out of that area. You can sit in a screened porch rather than an open porch. Um, and then you can just cover up with clothing, longer pants, shirts with sleeves, whatever, a hat, kind of protecting that way. And then we do recommend DEET, DEET, we think is our best. And it's a safe anti-mosquito agent. I like Deep Woods Off is potent. It lasts a long time, and it's very efficient. If it's the lower percent DEET products, you have to reapply them more often. And I actually was going to the area to Long Island, where there was initially West Nile and West Nile infection over 20 years ago, and I was pregnant, so I was very worried about using mosquito spray, and I did a lot of reading about DEET, and DEET is actually very, very safe unless you drink it. So do not drink it, and do not drink, or for a small child, if you put it on their hands, like they might end up ingesting or licking or but basically just don't, even if you do a little bit, it's okay. It's probably going to taste really bad. Don't do that. But yeah, you'll learn pretty quickly. It'd be very bitter, but yeah, DEET works very well. And so I think just try to avoid mosquito bites, but I will tell you, one mosquito bite will be okay. Okay, like one mosquito bite will be okay. Two mosquito, like it's not like, or one tick bite, it's usually not one or two. It's because sometimes I myself, I'm like, oh, I got bit by a mosquito, and then I start like worrying, and then I'm like, wait, it's just like one mosquito bite, like get over it. So usually it's fine, but we do recommend avoiding mosquito bites, and just be careful about the sun too. Transplant patients are at a higher risk for skin cancer, and so I think all of us have learned, wear a hat, wear high SPF lotion, cover up with clothing that helps against the mosquitoes. If you're driving in a car, think about your hands. Maybe you want to wear driving gloves if it's really sunny, or if you might get burned on your arms or something in the car that's exposed. I once had a sunroof and was wearing a sundress and got burned. Try to avoid those, like not like we're laying out on the beach so much, but those inadvertent sun. Yeah, but now that I've said all that, I think it's really important to have a great summer. We've all been like living under a rock for the better part of 4 years. COVID numbers are headed down. Flu's going to go away. There's still going to be some things out there. But you know what? Go out, live life, enjoy, get a COVID booster if you haven't had one recently. Live life. If you want to travel, if you want to talk to me about travel medicine, or I know that people come from different institutions, and certainly there are wonderful people at Tufts and elsewhere. I don't know where wherever you get care. If you do want to see me, I'm happy to see anybody. I'm a non-denominational. I'll see anybody from any institution. Yeah, and sometimes people just want to talk to me not so much about the details of where they're going, but they're like, I'd like to go on a trip, and I'd like to talk about A versus B versus C. And I often feel like a travel agent, but I'm very happy to talk to people before they book. Sometimes it's hard after they've booked, and I'm thinking, oh, that's kind of a high risk trip. And they're like, yeah, I spent $20,000. I'm like, oh, guess you're going, and I guess we're going to figure out how to make it safe. So happy to talk to people beforehand as well. We can kind of do a first pass and then a second visit, depending on details or whatever works.
Thanks, Doctor. So Don Mitchell had the question: for those who like to cruise, would you recommend traveling during non-peak seasons, fall and late spring?
That is a great idea. Yes, that sounds good. It's all, a lot of this is just playing the numbers, and a massively crowded, like crowded to the gills cruise ship at like over the holidays, or the peak times. The more people, the higher the risk. So also, if you can go on a smaller boat and less dense, is good. And if you're, depending on the details, if you could have dinner either earlier or later or in a like less crowded time. And then, if you're going through like, say you were at a less crowded time, but you have to go through like I don't know, a line or a buffet, maybe throw on a mask for the buffet. But then when you're sitting down, kind of far away from other people, then you take off your mask. I'm into the kind of like on again, off again masking. Just I wouldn't want to get sick when I'm traveling. I'm going to Spain next week for a meeting and I'll be masking on that plane because I don't want to be sitting in my hotel room. I want to be on the waterfront in Barcelona doing what people do on waterfronts in Barcelona. I don't want to be blowing my nose in a hotel room.
By the way, the waterfront in Barcelona is gorgeous.
Yes. Yes.
Uh, all right. Any more questions? I have one last question, but there's another question from the.
Oh, he's saying not during flu season, Don Mitchell. Yeah, not. Yeah, that's a good. I mean, I guess it depends. So just word up that depending on where the cruise is, so influenza season in the Southern Hemisphere is the opposite time of year from us. So it's actually pretty cool. We actually studied the Australians to check out their flu season, which is our summer. And then we see how well the flu vaccine worked on Australians. And then we say like, oh, this is what's coming our way. So it's like, it's pretty cool because it's flu is different. So far, we haven't really documented that COVID-19 peaks at the opposite 6 months in the Southern Hemisphere, or RSV. I haven't heard that, but we know that. So just think about where you're traveling, where people might be traveling from, and so take that into the equation. But I like those. I like those ideas. So less crowded ships, and then just think about where you'd go and what you'd do if you got, what if you got sick, and then maybe ask about the medical situation. And then Jill's idea about the having the additional jet insurance if you need medical evacuation is always a good one.
Thank you. So this is okay. Here's another question. And
Yeah. Oh, that's a good Jill Powers. So
okay.
she says, avoid buffets if possible. If you have, if you have to go to them to ask to bring the food from behind the line before it reaches the buffet. Yeah. So people aren't all coughing on it. Yeah. Tell your waiter you're immunocompromised and want them to take extra special infection control precautions. Tell your room steward, yeah, to wear a mask. We bring bleach wipes and clean the rooms ourselves. Yeah, Jill, we are empowered. Like we know. And most people, I think if you just said, would you mind, I'm immune compromised, would you mind wearing a mask? I think that for the most part, people are good people. There are a couple bad apples out there that ruin it for the rest of us, but most people are delighted to help each other if especially if it's a simple request. So,
Okay, so last question from me at least. Pneumonia and pneumonia vaccines.
yeah.
Uh, in transplant, they don't talk a lot about that. But if you look, I mean, pneumonia can be very dangerous for a transplant patient.
Yeah.
So what's the guidelines there?
So, in addition to the respiratory virus vaccines that I talked about, there is a bacterial pneumonia vaccine there are a couple out there, but Pneumovax is the old one. It was developed in the 1970s, and for a long time, it was all we had. It was like pretty good. Hey, man, it's better than nothing. And so then we developed these Prevnar vaccines. So there was Prevnar 7, and I wish I could show you. It is the most amazing information. When we started vaccinating children about 20 years ago with the Prevnar vaccines, we saw a huge decline in children for these types of pneumonias. But then if you look at the people over the age of 65, also the numbers declined. So when we vaccinated the children to prevent disease in the children, we saw that basically the grandparents really benefited by vaccinating the children. So pneumonia numbers have really, really, really fallen, which is great. And we went from Prevnar 7 to Prevnar 13, Prevnar 15, and we're up to Prevnar 20. The number refers to the number of types of strains that are covered. And Prevnar 20 is recommended if you haven't had a pneumonia vaccine, I'd say in the past 3 years, you should get yourself a Prevnar 20. It is like widely available. You can probably pop into CVS or Walgreens or wherever and just say like, hey, I'd like one of these. And if you're under a certain age, like 60 or 65, they might say, oh, I don't know. And you can say, I'm immune compromised. And I think they should usually give it to you and it should be covered by insurance. So Prevnar 20. There is in cutting edge, like what all the cool kids will want is Prevnar 21. Because Prevnar 21, not out yet, but it is even better coverage. Like at the CDC, we're talking about whether we're going to like really see the end of much pneumonia through Prevnar 21. I would get, if you haven't had a pneumonia vaccine in the past 3 years, I would go ahead and get the Prevnar 20 or talk to I should always say talk to your providers. I'm really bossy. I don't know. I was the first child, sorry. So I'm really protective of people too. Um, and so yeah, I'd get the Prevnar 20. And then in the next couple of years, when Prevnar 21 comes out, most likely, you'll get that too. So yeah, never let the sun set on an opportunity to prevent an infection.
Thank you. Thank you so much, Doctor. Any other questions from the audience? Hearing none, thank you so much, Doctor. Can't really truly convey HeartBrothers appreciation for supporting us and for supporting these webinars and educating the heart transplant patients. And we will put the recording of this program on our website so it's available to people, patients for a long,
Great.
long time. Thank
I'm
you.
so glad. It's really a pleasure to be with you all and to talk about prevention and travel. So enjoy. I hope everyone has a
I
lovely.
think one last question came in. Let me just check.
It's just
No, from no, these are thank yous coming in.
okay.
All right.
Good. Thanks, Phil.
Thank you.
Nice to see you all. Great.
All right. Okay.
Take care.
Thank
Okay.
you. Bye bye.